Bismillah ar-Rahman ar-Rahim. The lecture today will be about neonatal and pediatric tubes and lines. The lecture is by Dr. Ahmed Elhagar. He is my brother, and by me as well, Moustafa Elhagar. This is the first slice of our lecture. The question here, how many tubes and lines in the study? You can share your answer in the chat. I know the issue of tubes and lines is like a mirror for some doctors. And we will spend more time commenting on the devices more than the organs. In this topic, I will try to simplify and make a quick review for me and for you about the neonatal and pediatric devices. Okay, let's start now. I will try to see the answers and see 5, 4, 4. Okay. Thank you for sharing your answers. Tubes and lines. I will talk about the purpose, the appropriate position, the potential malposition location, the complications, and the percentage of malposition. The first tube is the endotracheal tube. It's used for ventilation and airway maintenance. The optimal position for the endotracheal tube will be in the mid-trachea, midway between the inferior margins of the clavicles, the level of the clavicles and the carina in children. In neonates, it will be about 15 millimeters above the carina. It's about 1 vertebrae and a half. The malpositions could be in the bronchus, could be in the esophagus as well. The complication may be trauma, may be infection and aspirations. The percentage of the malposition is 5 to 28%. The second tube is the tracheostomy tube. It's used for ventilation. The appropriate position of the tracheostomy tube, it's like the endotracheal tube. The tip should be 1/2 to 2/3 of the distance to the carina. The tracheostomy tube, the position is like endotracheal tube. Malpositions may be as well in the esophagus as well. The complication may be bleeding infection. 10% of malposition. The next one is the chest tubes. We use chest tubes for pneumothorax, or if there is any pleural or extra pleural fluids or collections. The position of the appropriate position of the chest tube, it's 4 to 6 intercostal space in the mid anterior axillary line. This is the optimal position of the chest tube. The malposition may be in maybe in heart or great vessels. The complication may be bleeding, may be causing nerve damage. The percentage of malposition, it's 30%. The nasogastric tube, it's used for feeding. The appropriate position, it's in the stomach, in the pyloric part of the stomach. The malposition may be high, maybe in the upper esophagus, maybe in the trachea. Complications, aspiration, maybe causing trauma as well. Malposition is less than 15%. The next one, the central venous catheter or the central venous line. We use the central venous lines for administration of medications and fluid and dialysis as well. The position may be in the superior vena cava or inferior vena cava. The malposition may be in the right atrium, to be in the heart. Complication may be infection, thrombosis. The percentage of malposition, it's 2 to 7%. The next tube is the umbilicus or umbilical venous catheter. The appropriate position is the inferior atriocaval junction, usually at the level of the diaphragm. Malposition may be in the heart or maybe in a low position. The complication may be infection, perforation. The percentage of malposition of the umbilicus venous catheter is very high. It's less than or equal 27%. The next tube or line is the umbilical arterial catheter. It's used to measure the blood gas. We have two appropriate position for the umbilical arterial catheter. There is a high position and there is a low position. The high position, it will be between thoracic 6 vertebrae to thoracic 10th vertebrae, and this is the preferred position. The other position is the low position, which is between L3 to L5. Malposition may be high position or maybe low position. The complications may be cause vasospasm. The complication of it as the umbilical venous catheter, adding to it the vasospasm. The percentage of malposition, it's 35%. Other tubes, the ECMO, the umbilical catheter, the temperature probe, and also Robles tube. Now we will go through the endotracheal tube. Just a minute. Like to okay, this is the endotracheal tube. Here we can see the clavicles. The clavicles are here. And the yellow is the trachea and the main bronchi. And the green line here is the level of the endotracheal tube, which is in appropriate position. As I mentioned before, in neonates, we should take care about the position of the endotracheal tube because it will be about 15 millimeter above the carina. This is the next case for endotracheal tube. Here, this is the tip of the endotracheal tube here. And here, this is the diagram again. The green line is the level of the endotracheal tube. Sorry, I will try to share my all screen to go to the full screen.
Dr. Mustafa, sharing stopped, I think.
Okay, I will start sharing my screen. Sorry.
Yes, yes.
Sorry, I have a lag in the computer. Okay, this is the next one. We can see here the endotracheal tube is located in the esophagus here. And this is a diagram for this. The trachea and the bronchi are lined by the yellow color. And we can see here the endotracheal tube is located in the esophagus, which is malposition here. And the green, yellow for the esophagus. Here as well, the intracheal tube is seen at a low position. It's about the level of the carina. Here, the next one as well, it's in a low position. Here, here as well, it's at the level of the carina. And we can see the tip of the intracheal tube at the level of the carina. Here as well, it's at a low position at the level of the carina as well. The next tube is the tracheostomy tube. This type is the armored tracheostomy tube. The tip should be midway between the carina and the level of the clavicles. It's like the intracheal tube as well. It's in position here. The next one. I'm sorry about the lag. Okay, this is we have here another tracheostomy tube. It's seen at a low position. It's about seen in the, sorry, here, the tip of the of the tracheostomy tube, it's about the proximal part of the right main bronchus. Here, the next one. The next tube is the chest tube. The appropriate position is between the fourth to the sixth intercostal space in the anterior mid-axillary line. And here in the image, the tube is in appropriate position. And also we should take care about the side holes of the chest tube. The side holes should be inside the the hemothorax inserted in and not be in the wall outside. And here we have another chest tube in the left hemothorax and seen as well in appropriate position. Here another chest tube which is seen in appropriate position. But here the endotracheal tube is seen at a low position, seen at the level of the carina here. The next one, we have in the right hemothorax, we have two tubes. One is the normal chest tube and the other is the big tail one. And both are in position. We have as well in the upper edge of the film, we have the endotracheal tube, which a little bit high if we measure. This is a unit, and if we measure the distance from the carina to the tip of the endotracheal tube, looks a little bit high in position. The feeding tube, the nasogastric tube, lower end not included in the image. However, it seems to be in position. We have as well here the umbilical venous catheter. I will come in the next slices, which seen in a high position here. And we have as well a clip for a beta ductus arteriosus. The next here in this slice we have a right-sided pneumothorax, which is a tension type because there is displacement of the mediastinum to the right, to the left side. And here the chest tube is inserted. However, we still have a pneumothorax here on the right side. We did CT chest for the same patient, and we find that the chest tube is still in the extra pleural space, so it was not working well. The next tube is the nasogastric tube. The normal position of the nasogastric tube in the stomach, in the pyloric antrum. The malposition may be high in the esophagus, maybe in the trachea. Here we have another nasogastric tube which seen in place. Another nasogastric tube which seen in place as well. Another one which seen in place. In this film, we have the nasogastric tube. It's seen in the distal part of the esophagus, so it's not crossing the diaphragm, so it's seen at a high position, needs to be repositioned. In this film, we have a left-sided inserted peripheral catheter, which we will discuss in the coming few slices. The yellow line at the level of the tip of the feeding nasogastric tube. What do you think about this tube? You can share your opinion about this tube. What's the type of the tube? And is it in position or not? Sorry, I will try to see the answers. Okay. We need to know the difference between the nasogastric tube and the nasojejunal tube. In this image, we have the jejunal tube here. And in the image here, we have the nasogastric tube, which is malpositioned in the left bronchus by the blue line here, which is malpositioned. This one is the nasojejunal tube, and the blue one is the nasogastric tube, which is malpositioned. Here we have a malpositioned nasogastric tube, which seen going down through the main right bronchus. And in this image, the nasogastric tube is rolled up in the esophagus, and the tip is seen at the mid thoracic esophagus here. It's malpositioned here by the yellow line. It's went down. After that, it came up, and the tip seen at the mid part of the esophagus, so it needs to be repositioned. In this image, the nasogastric tube is rolled up as well here in the proximal esophagus. And we have here also the endotracheal tube, which is seen at the level of the carina, and this is a low position and needs to be repositioned. And at the left part of the film, we have a peripherally inserted catheter. And we have on the right side a central line as well. In this film, this babygram, we have the nasogastric tube coiled in the upper proximal esophagus. And we have as well, you feel there is a gas-filled pouch in the upper part of the babygram. And also, if you take a look to the spine, the upper part of the spine, the proximal part of the dorsal spine, we have segmental anomalies in the vertebrae. This is a case of tracheoesophageal atresia with distal tracheoesophageal fistula. This is the case of Vectral. And this is another tube. This is suction tube called Robligal tube. This one here. Usually used when there is esophageal atresia. The name is Robligal tube, suction tube used for suction. Here another malpositioned nasogastric tube which coiled in the proximal esophagus. What do you think about this tube? Anyone have the answer? He can share his answer. This is not an esogastric tube. This is pH probe. This probe is used to measure the esophageal pH as a part of gastroesophageal reflux workup. What about this tube? This is temperature probe. It's in place. It's inserted in the esophagus, used to measure the temperature. This is esophageal temperature probe. I think the zoom is obstructing part of the image here. This is a big tube. This is another big tube. And the arrow is pointing to free intra-abdominal gas. Big tube, this is the percutaneous endogastric tube. And the arrow is pointing to a free air seen in the intra-abdominal cavity. Here another big tube. And we did lateral decubitus film, which confirmed the free air seen in the intra-abdominal cavity. After that, we will go to the vascular lines. The normal position may be in the superior vena cava or inferior vena cava. So between, if the line inserted from the arms of or from the neck, the central vein, it shouldn't go below thoracic vertebrae 4. And the vascular line, if it's inserted from the lower vessels, it shouldn't be above thoracic vertebrae 9. This is the area of the heart. Here we have right peripheral inserted central line, which is seen in malposition. It's seen in the heart, in the right atrium. So the line should not be below thoracic vertebrae 4. And in this image as well, we have malpositioned peripherally inserted central catheter. The catheter is passing through the patent foramen ovale to the left atrium. Here, this image. And here as well, we have another malpositioned peripheral inserted catheter. In this image, the tip of the catheter is entered a pulmonary vein here. In this image, we have a malpositioned in the left, it's left inserted peripheral central line, which is malpositioned as well. The catheter here, the tip of the catheter is one of the hepatic veins. Here, this is the level of the axilla. Here, the subclavian vein. And here, it's left superior vena cava. It's a variant here. This is the sinus, the coronary sinus. Here is right atrium to the IVC and to the hepatic vein here. So it's malpositioned. And we have a variant here in this case, left superior vena cava, because the superior vena cava should be in the right aspect of the vertebral column. And here as well, we have another malpositioned right peripheral inserted catheter. And this baby has fragile bone and multiple fracture. This is a case of osteogenesis imperfecta. And here another malpositioned vascular line here. And here another vascular line, which is malpositioned. It's inserted in the left side, and the tip is seen in the right subclavian vein here, malpositioned as well. This is the course of the line. And the feeding tube seen at a high position by the blue dark lines. And here another central line, malpositioned as well. The tip is seen in the subclavian vein. And the feeding tube is high as well. We have a vascular line inserted from the left lower limb, and the tip is seen at the level of the diaphragm. It's a normal position. Another vascular line inserted from the right side, and the tip is seen at a low position. Another central line here as well. The central line is inserted from the left lower limb here, and the black circle at the level of the tip. The line is going up at the left side of the vertebral column. Should the IVC on the right side. So may we have a vascular anomaly here. We did lateral view. The line here is seen in lumbar vein. Another vascular line. We have here the Bermacase. It's used for dialysis. It's bigger than the sorry. This is the Bermacase. It's used for dialysis, double tunneled. This is the Portacase. It's smaller than the Bermacase. It's used for chemotherapy usually. And if we take a look to the left scapula, it's removed. Was a case of Ewing sarcoma, and the baby is taking chemotherapy through the Portacase. Sorry. This image shows the left scapular lesion before removing the scapula here. Sorry, I will go again to the image. This is the Portacase. Here, we have aggressive lesion on the left scapula, which proved to be Ewing sarcoma. Now we will go to the umbilical venous catheter. I think the time is up, so we can discuss it in another lecture. Thanks a lot.
Okay. You have 2 minutes if you like to finish.
Okay, Dr. Mahmoud. Okay. This is the umbilical venous catheter. The optimal position at the level of the atriocaval junction, the inferior one here. And this is malpositioned. And this one is high, it's entered the heart. To simplify the normal position of the umbilical venous catheter, it's at the level of the diaphragm. Here it's low positioned as well. I need just to go to the umbilical arterial catheter and finish the ligature. All of these are umbilical venous. This is the umbilical arterial catheter. Usually they use the high position. To simplify it as well, it will be above the diaphragm and below the arch of the aorta to be away from the great vessels. So the optimal position of the umbilical arterial catheter will be above the diaphragm and below the arch of the aorta. And thanks a lot. Thank you.
Thank you, Dr. Mustafa, for this amazing, comprehensive review about the lines tubes.
Thanks a lot, Dr. Mahmoud.
Very, very important for the exam. I see some question. I don't know if you have a time for 1 minute, 2 minutes to answer something, or
I don't know if there is time,
in
but
the
I
chat.
can.
Yes, if you check this
Okay,
chat.
I will. Okay, I will review the quizzes, and they can answer on the chat.
Okay.
This is the first quiz.
Yes, I think it was just in the while you are scrolling through the cases. Yes. I just want to mention something that at 7 p.m. There will be a reporting session, which will be the first time we will do in this scientific day, and it will be like very simulating to real practice and real exam cases. Dr. Muhammad Amin will be there in this session today. It will be unique for this day. Now we have a break. And Dr. Mustafa, did you, there is any question we have to answer, or should we take a break?
I can share the quizzes, and they can,
Yes, okay.
anyone happy to answer the quizzes will be very nice. And this is the first quiz.
Yes, okay.
This is the first one. I will leave it for a few seconds. After that, I will move to the next quiz. This is the first quiz. Anyone happy to answer it in the chat? This is the next one. There is a lot of tubes here in this babygram. What do you think about the umbilical venous and arterial catheters here? Okay, this is the next one. My question here, what is the cause of the ossification of the right upper lung loop here? Here, this is the next one. This is the next one. And this is the last quiz. We'll try to see the answers. Yeah, I can see the answers now. Okay, thanks a lot. I hope you enjoyed the lecture.
Thank you, Dr. Mustafa, and thank you
Not
for
the
this
problem.
amazing lecture. We'll take a break. And again, don't forget the unique today reporting session. It will be at 7:30. And I think it will be something unusual. And inshallah, you can enjoy it as well. Next, it will be after 10 minutes with Dr. Mahmoud. Inshallah, we are waiting. So take your coffee and come back, inshallah. See you then.